Two, one. Sir, we are live now.
Okay, thank you, Marshi from OrthoTV. So welcome all of you for this month's tricky case of the month session. Very interesting ritual we follow at Orthokids Fellows module. And today we have three experienced experts. I mean, experts are experienced always. And you all know them. Dr. Jayant Sampath from Bangalore, Dr. Anil Agarwal from Delhi, and Dr. Atul Bhaskar from Mumbai. And they have huge experience in the field. The key thing today is the cases which we are going to show. They know only that much which you know, so they have not been shared the cases prior. The reason was their thinking process will guide you how to think about when such situation arise. And I'm sure at the end of this session, you will see some very rare presentations of orthopedic ailments, which you will not forget in your life. And the main purpose is not to test anyone here, because we ourselves are baffled while reaching to the diagnosis. So we'll just like to share our experience with you. And we have two fellows, Dr. Goda and Dr. Jayant. So they will present cases, and we have some non-orthopedic experts also here. So yeah, Goda, shall we start?
Yes, sir. Good morning, everyone. So the first case is of a 3-year-old child who presented with knee pain, which was not subsiding. A 3-year-old girl presented with complaints of pain in the left knee and leg for 15 days. There was no history of pain in other joints. There was history of trauma 1 month back. The history was given by parents. She had a fall, and the child was able to walk post injury, and she did not complain of any specific inability to walk or move post that. She does not have any history of fever. And the parents reported that this pain was insidious in onset and it gradually progressed. They also reported that she complained of on and off back pain since a month. There was no history of morning stiffness. And the child was taken to few orthopedic surgeons who advised x-rays to rule out trauma. And the x-rays did not reveal any significant or obvious injury, except for some osteopenia. She was given analgesics and sent back, but the pain did not subside. So she was taken.
Goda, can you stop there?
Yes, sir.
And Jayant, this is the history. This is the age, a 3-year-old girl with, can you go back to the slide, Goda? And as you see, she has pain around left knee. All the times the family would collaborate it with trauma. And the thing I asked to the mom is, was the child able to walk after the trauma? And they would invariably say, yes, she could walk, but after a few days. So they collaborated with trauma. And she also had some on and off back pain, which was kind of non-explainable. Next slide, Goda. And a couple of senior orthopedicians in Ahmedabad have seen, and they have just prescribed analgesics. So just based on this history and the X-ray, what possibilities would come to your mind, Jayant?
So the top 3 diagnoses are obviously trauma. There is some injury to the knee. Number 2 is infection. Or number 3 is some kind of systemic illness, because there is also a history of back pain. So
right.
All 3 of these major disease categories, I think I would initially keep in mind, and
right.
then based on further information, I would slowly rule out the others.
Great. So Dr. Anil, would you like to add in what Jayant said, anything else?
I would just like to include one more differential, that is of radiating pain to the knee, because there is a history of back pain. So beside the 3 differential diagnoses Dr. Jayant pointed out, I could assume that the knee could be secondary pain because of some spinal issues or secondary
Spinal
to
issues, yeah.
Yes,
Radiating
yes.
pain. And Dr. Praful, he says there might be some hip pathology also, which is radiating to the knee joint. So, Praful, we are coming to examination part, but that's a valid point. So, whenever a knee pain, we have to think about these 4 or 5 things which Dr. Jayant and Dr. Anil Agarwal mentioned. So, let's move on further, Goda, and show
Yes.
what is happening. Yeah.
So she was given few splints and a slab for few days, and still the pain did not subside. So what could be the cause of this pain is what we thought.
So probably the senior colleagues, they thought that this child might have some hairline crack or some marrow, trabecular injury. And so the key thing is they just put a splint on for some day, for a few days, and then call them back. But patient had persistent pain. Lateral view was also not conclusive. Gaurav, it was looking normal, just like an AP view. That was not very significant finding on X-ray. So we'll keep, Atul, what investigations you would advise from here?
So one more thing I would like to know, was there any limp? Was the child able to squat and get up? And was there any night pain? So I think a couple of
Yeah, so actually the child was sleeping well at the night. That's I inquired. Secondly, child was actually a bit irritable, and she could sit up from the, she could sit up from the sitting position. So there's not like myopathy or something, or a stress fracture kind of thing. She could walk also, but she would constantly complain of knee pain. And when she was lying down, getting up was problematic. For last few days, mother had to support her in sitting up.
So, I would definitely get the routine blood test done, CBC, ESR, CRP, liver function test, alkaline phosphatase, get X-ray of the spine, and the hip joint as well.
Right.
Get a USG abdomen. And also, I've got a similar pattern of case. I don't know whether it evolved, but that actually evolved into a GBS. Came with leg pain and 3 weeks of limping, and then eventually, so I would get basic investigation done, X-ray of the spine, hip, USG abdomen, and the routine blood test at least to begin with.
Yeah. So Dr. Anand, here, pediatric neurologist here. Anand, you are here. I asked them to join in the second case, so he might not be around. Anyway, so he treats a lot of GBS, but the GBS patients, do they present with pain, Atul? They have.
Yeah, so I had one child who came with actually symptoms of synovitis, transient synovitis referred to me.
Okay.
And his pain actually progressed rapidly from one leg to the other leg. So that's why I was suspected.
Maulin, can I join in?
Yes, please.
Yeah, what is more important here is that what are the examination findings? Is there anything which is tender in the knee area or the hip area?
So I think we are coming to that in a moment. Let's finish the examination part, and then Dr. Gupta, you can comment. Yes, Goda?
Yes, sir.
Yeah, please show the exam.
Yes, sir. So she presented to us then, since her pain was not subsiding, and the child was very irritable, but there was no obvious swelling either in the thigh or knee or leg. There was diffuse tenderness in the lower thigh and calf, and the child did not allow movement of the knee. And on examination of spine, there was tenderness along the thoracic and lumbar vertebrae. Apart from that, the hip movements and all were quite good. So these were her examination findings. And after this, we thought we'll get radiographs as well as some blood investigations done in the same sitting. So when the patient came, we got few radiographs done, and the X-ray of the spine lateral view as well as both knees AP, except for some diffuse osteopenia, there was not a very significant finding apart from
this. So Goda will stop there. So Amardeep is saying discite is also a differential. Yes, Amar, that's right. And as pointed out by Dr. Anil, it can be a referring pain. Dr. Gupta, I'll come back to you. What do you? This is the examination points. Would you like to add into this?
Yeah,
Can
I
you go
mean,
back
what
to
is the
that slide?
examination of the knee like? Examination of the hip like?
Hip is normal.
Is
Go
normal.
back
So
to
if
the slide.
you have, yeah. So if you have a situation where there are areas of multiple involvements, I think some sort of systemic disease should be
Yeah,
thought of as the possibility.
that's right. So that's, I was also thinking that something systemic is going on. Right. And X-ray was not showing anything great except some osteopenia, which we see in some cases. Jayant,
One more thing which I wish to add on the lateral spine X-ray is that the lumbar lordosis seems to be a little less as compared to what you expect.
yeah. And I mean,
don't know
child
whether
was
that's
a bit I would say that irritable, and she was not kind of positioning as we wanted her to. But I mean that I won't say that loss of lumbar lordosis, because the X-ray was not in reliable position. Is Gaurav, you said PBF? What is it? Abdominal pain nahi hai usko. There is no
Peripheral
abdominal.
blood film to rule out any blood related disorder.
So let's come to, we have already sent the blood test. SSAPs क्या होता है? Praful?
Seronegative spondyloarthropathies.
Okay. Yeah, but there is
So
no
kind of
morning.
spot.
Yeah. So, but yeah, that's a possibility. But the child was not having morning stiffness and having, but that is a possibility that inflammatory cause can be there. So we advised investigations, and now we'll take you through this the case, and then we'll talk further. Yeah, Goda.
Yes, sir. So, along with the radiographs, we got an MRI and simultaneously sent the blood samples also, and we were awaiting the results of it. So the MRI came back, and this was done actually to rule out some infective conditions or a suspected intra-articular anomaly or injury. So the MRI reports came back, and except for age-related bone marrow changes, which we can see on the right, and some amount of edema in the vastus lateralis, and there was some very mild wedging of the L1 vertebra. Apart from this, we did not get anything obvious.
So I talked to radiologists at this point, and they said that L1 wedging is there, but there is no marrow edema around or no soft tissue edema. So it might be a chronic thing. And there is some vastus lateralis edema, as you can see. Rest, every screening of both the lower limbs, pelvis, abdomen, everything was normal. So now what, Jayant?
So I would look at the blood picture and get a bone marrow.
Right. So let's go further. There was no intra-articular knee anomalies, discoid meniscus or ligamentous thing. And by the report came, the blood test also came. Yeah, Guda, you want to go ahead?
Then we got back the blood investigations. The reports came, and the hemoglobin was very low, but there was a significant increase in the WBC count, and the platelet count was reduced. At this point, peripheral smear also was done, and we wanted to seek the opinion of an expert pathologist. So a senior pathologist opinion was sought now in view of abnormal blood counts.
Yeah.
Should I proceed?
Yeah, please.
So, as suspected, the peripheral smear revealed 25% blasts. There was decrease in neutrophils, and the peripheral smear was very significantly suggesting acute leukemia.
Yeah, so as Gaurav and Jayant mentioned, and as other experts, that we have to think about something systemic going on. And many a times in these leukemias, we cannot collaborate all the findings, but they have a lot of osteoarticular pain. Yeah, Goda, go ahead and show.
Yes. So then we referred her to an oncologist, and bone marrow aspiration was also done. And it was also suggesting of acute leukemia, and the hematopoiesis was suppressed by about 90% blasts. And then they also got immunophenotyping done, which was consistent with B lineage lymphoblastic, that is precursor B lineage ALL. And then the child was referred to an oncologist and started on chemotherapy. She has received around 2 cycles of chemo. As of now, her knee pain has subsided, but back pain is still persisting.
So, yeah,
There's
Goda, you
a
can
lot of
finish your
pain in the
presentation.
neurology literature.
Yeah, just a moment.
Yeah.
Let her finish
yeah,
her
you got it.
presentation. We'll
Okay,
talk
great.
further.
So this was one publication in Pediatric Rheumatology Journal, which suggests that whenever there is intense metaphyseal bone pain, which is of sudden onset, it always points towards ALL rather than JIA, because in JIA it's more progressive joint pain. So what was a learning lesson in this case is that any severe pain of short duration with a very irritable child, always malignancy should be included in the differential diagnosis.
Right. So, Gaurav, I inquired with our hemato-oncologist, and she said that 70% survival rate is there, and that means that 30% patients may not do well, and mortality is also seen in this. So, there's a very unfortunate situation that child has been to different colleagues, and that's a routine story we see. They treat it with some simple problem, and we missed about 1.5 months for this. If the child could have come to us or any pediatric orthopedician earlier, then we could have gone in this depth, and child might have received medications earlier. But she is doing well at the moment. 2 shots of chemo has been done. Yes, Atul, please.
So just 2 points.
Yeah.
Whenever the symptoms are more than signs in a child,
Exactly.
particularly persisting beyond 2 to 3 weeks. So 50% of children with bone pain can present with leukemia. Other thing, I think if you look very carefully, we had a child similarly with the low, we presented like the 9-month-old child actually, and had bone pain and also petechial rash. There are a couple of petechial rashes, 1 or 2 on the back and on the thigh. And the pediatrician then suspected this could be a blood dyscrasia. And I think those are very subtle signs. I think want to strip the child and examine them thoroughly, so you don't miss these things.
Right.
So the other thing is to do a bone marrow. So
Yeah.
a lot of times you will get it on the peripheral smear. But
Exactly.
I've had many cases where the peripheral smear is normal and only a bone marrow will tell you that it's a leukemia. So don't rely on the peripheral smear, looking for blasts, etc. In very early leukemia, this was, I think, a little bit delayed, 6 weeks. So we were able to pick up blasts in the peripheral blood. But in early leukemia, if within a week or 2 of symptom onset, always never hesitate to get a bone marrow. It's a very, very simple investigation to do, and it will save you a lot of headache later.
So, Jayant, what I do is, I involve hematologist and see whether if you find any doubt, you do it. Yesterday only I got a case where this pain is not subsiding for 3 weeks now. Naproxen has already been given, and there is a lesion in tibia. So I have asked them to see a hematologist, and as you said, the smear is normal. So maybe if they like to do bone marrow, they can definitely do it, and we can catch up the early cases. Deepak, the osteoporosis might be because of the marrow infiltration as well as the immobility of child. Now, I mean, we have a lot of discussion with our radiologists. They have different patterns of marrow infiltration in different age group, and Goda will share that slide with you. That and sometimes a radiologist may also do mistake in defining this marrow changes. They might see that this is the normal change according to age, but that might be different. Right, let's move on to the next case. Amar, you rightly said we have to involve the elite specialty. Jayant, you want to share your screen?
Good morning, everybody. The second case. So this is her story. 7-year-old girl. She presented with a sudden onset left upper limb weakness since 2 days. And how the parents noticed this was when she went to the washroom in the morning, she couldn't help herself. And that's when they noticed that she had a left upper limb weakness. And then later the girl said that she fell on her arm 2 days ago, but it was not associated with any swelling or any tenderness in the cervical spine or clavicle or shoulder. And also she did not give any history of tingling or numbness. And there were no weakness in any other limbs and no history of fever.
Right. So with this history, Dr. Anil Agarwal, 7 years old girl, sudden onset left upper limb weakness, 2 days. 2 days ago had a fall. And there is no pain actually anywhere or tingling numbness. What differentials would come to your mind at this point?
Sir, the child doesn't give a very short history of trauma. Had it been a significant trauma injuring the neck region, then she would definitely have been caught by the basically. So trauma doesn't seem to be a cause. It manifested suddenly. So I would first keep the infection side first.
Right.
And I would like to inquire the weakness. It's just stated that there is a weakness of the upper limb. Which region? Just the hand portion, or the elbow portion, or the shoulder portion? What is affected basically?
So we will show you the video. The parent said that the grip, she could not use the flush, or she could not hold the brush well, which she does routinely. And then the child told this history to mom that I'm not able to hold the brush or the other things. And then they recognized. So they just came with a history of weak hand. And then we'll show you the video that the weakness was not only in hand, but other places as well. So Atul, any differentials you think at this point?
Was there any predisposing viral fever a few weeks ago?
They say before a week she had a viral illness, and she received this symptomatic treatment for 2-3 days, and she was okay thereafter.
And the weakness has been progressive? Has it been going from?
They just they observed, and they went to their pediatrician, and he thought that this must be brachial plexus burst palsy. So they referred to me. All these patients, they are referred thinking that it's a BPBI, and parents might have not seen, you know. So there's the same day afternoon they came to me.
Right. And there's no burning sensation in the
no. There is no burning, tingling. So traumatic brachial neuritis, this Deepak is saying, and so as Gaurav. So some brachial neuritis is, one should think, that's right. Jayant, any other thing? Or
you can get an X-ray first. I mean,
so let's see the examination and video of the child. Jayant, and then we'll also show you the X-rays. See, the wrist remains kind of dropped. She can do abduction with trick movement, and she cannot hold the arm for long. She is not irritable, you know. It doesn't look like that she has some pain anywhere while doing this movement, but she is not able to sustain. And parents are really worried because she is a very active child. Every time she is dancing around, so they could really find out the difference. And you can see she is not able to hold very firmly. Tendon reflexes, as Jayant has mentioned, they are brisk. There's no sensory deficit.
What about the plantar response?
Plantar response was, frankly speaking, I did not check. We were focusing on the upper limb only. So I have a pediatric neurologist colleague here. We'll bring him in a short moment. Right. So let's show the X-rays, Jayant.
Yeah.
blood investigations.
So we got some blood investigations done and they came back as normal. We got C-spine radiographs and they also did not reveal any bony injury. And we got shoulder and clavicle x-rays, which were also normal.
So at this point, a pediatric neurologist friend, because this brachial neuritis we were suspecting, so that was sent to our colleague, and he primarily did EMG NCV, and he said EMG NCV is absolutely normal. So Jayant, you show these images.
So Maulin, what I think here is that if both the sides are involved.
No,
then...
it's only one side,
Left
only
side.
left side.
Okay.
The MRI scan done, MRI of the spine, cervical spine.
MRI spine is normal. It will come, but it was reported normal. NCV is also normal. So any clue, anyone?
So did you investigate the occipito-cervical junction?
That is normal.
Because you said the tendon reflexes are bis, so the lesion has to be higher than the C4 level. So we have to look higher. We have to look higher then.
Yeah, but MRI is normal at cervico-occipital junction is normal. So Anand, are you here with us?
Is there some kind of focal myotonia?
I'm here.
Yeah, so I welcome Dr. Anand here, who is a very renowned pediatric neurologist. Anand was consultant at UK for about 8 to 10 years, and we have fortune to have him in Ahmedabad. Is very nearby. So I called him that and I told all this confusion which we all have right now, and he could diagnose the case right just from the history. So Anand, can you or let us show the further image. Anand advised a brain MRI, and can you show the brain MRI, Jayant? Yeah. And now, Anand, can you elaborate what it is?
Yeah, thank you, first of all, Maulin, for inviting me to this. So before I go on to the MRI, when I examined the child, I could see a subtle left facial weakness. And of course, when I asked her to walk, we do something called the Fox test, or we make them walk with difficulty. And they immediately had the left hand was held in posturing. So I could clinically make out that this is more likely to be a hemiparesis with more involvement of the upper limb rather than the lower limb. So, but yet I thought that coming from orthopedics, I should, and because it was 3 days post the event, I did think that if there was a brachial plexus injury, we should see it in the nerve conduction. So I did a very quick upper limb focused nerve conduction, and then I sent them for the MRI. So this is on the left of your screen, you have your diffusion weighted images, and this shows diffusion restriction in the right frontal region, extending all the way up to the central sulcus. This is the ADC map, which also shows corresponding diffusion restriction. And on the right of your screen, you have the MR angiography, which clearly you can see that there is a cutoff of the right internal carotid artery. There is a block over there, and there is extensive revascularization around that area, which gives the appearance of a puff of a smoke. And this is a very typical history. The fall and then the hemiparesis is very typical for Moya disease. So this is what when I was driving to clinic, as Maulin had called me, and I said, it sounds like a stroke, it sounds like Moya. And it was just, coincidental that it came back as Moya as well.
Yeah, so I was so surprised that in my 15 years of practice, I've never seen a stroke child presented like this, like Moya disease as a differential of brachial plexus neuritis. And I was so happy that I involved Anand right away. And can you tell more about Moya disease, Anand? How it presents, and what is the prognosis, and what treatment we should?
Yeah. So moya moya is more common in Asian population. It's more common in Japan and China, but also in India. Its prevalence it's very rare. It's about 0.5 in 100,000 children. And the main symptoms are stroke, headaches, and seizures. These are the common presentation. Um, um, Usually, children tend to have repeated episodes of transient ischemic attacks involving both sides or the side where there is stenosis. And it is said to be a progressive cerebrovascular occlusive disease. So it can be occluding one side, it can be occluding both sides. So serial follow-up with repeat MR angiography is what is indicated in this condition. And there are certain staging criteria, it's called Hawkins staging criteria, depending on the symptoms, depending on how much occlusion is present. And primarily, the treatment involves two main things. One is aspirin, because these collaterals are poor flow vessels. So there's chances of platelet occlusion or flow not going properly. So you essentially give aspirin, sometimes even clopidogrel, to make the flow smooth. And in most cases, this reverses the symptoms. The flow gets reestablished and the child improves just with that. The headaches also respond very well to antiplatelet management. The second management is sometimes if they have repeated episodes, then we can give calcium channel blockers like nimodipine or very rarely verapamil, because that kind of causes vasodilatation, and that might help, again, revascularize the area. But the most important is surgical management of these children, particularly those who have bilateral disease and if they have repeated episodes, because it is a progressive condition. And the two, or rather three main surgical approaches are, you do an anastomosis. I mean, this is the neurosurgeon's forte really, but you do an anastomosis from the superior temporal artery to the internal carotid artery. So that is the anastomosis. The second procedure is indirect revascularization. So this is called encephalosynangiogenesis. So you take a dural strip, you take a muscle strip, or you take a dural strip and you attach it on the surface of the dura. So that causes revascularization over 3 to 4 months, and it provides blood to the area of the brain that is not receiving adequate blood supply. And now there is more evidence to say that both these procedures together might help. The anastomosis might help in the short term, whereas the dural or myoencephalosynangiogenesis will help in the longer term. So eventually, many of these children will go on to have neurosurgery, depending on how they progress. Some of them will just have a static course. Some of them, many of them, I would say, will have a progressive course. And if it progresses, then we will need to refer them to neurosurgeon, vascular neurosurgeon. Actually, somebody who has got expertise in vascular neurosurgery is indicated for this procedure.
Right. So that's great. And one of the questions from Gaurav is, can we see this in adolescents also? What's the common age group we see this?
Usually in school age children, that's what is common. But yes, it can also present in adolescents. It can present in any age. Sometimes, even young adults present with stroke and they actually have moya moya.
So the key thing is, we did not check the lower extremity. And as Dr. Gupta mentioned, we should check the weakness in the lower extremity. Sometimes in young children, our examination is not reliable, and that creates a problem. But this thing should be kept in differentials. And Jayant, would you like to move ahead and show what further treatment and yeah.
So as Sir described, so moya moya disease is more common in East Asian populations, and it has a bimodal peak of incidence. And this was a couple of weeks after initiating her treatment.
So she has improved partially, but Anand, as you said, that we have to, the patient needs to be in your touch constantly to see the progress. Yes, any comment from experts? I mean, this is for the first time I have seen this in this 17 years. So I thought we must share this case with you. Jayant, Anil, Dr. Anil, have you seen similar case?
I have heard it being discussed in our Rainbow Pediatric meetings, only because it has a very fancy title, Moya Moya, so it kind of tends to stick in your head. But I've never had any of them present to me as an orthopedic case. But it's very interesting. So because we do get monoplegias, we do get, in a pediatric orthopedic practice, I think it's not uncommon. Probably once a year you will see a presentation like this. So to have usually we think it's parsonage turner, brachial, post-viral brachial neuropathy. But I think Moya Moya is, now it kind of sticks in your head, and I think it's something that we'll certainly bear in mind for the future. That's a very, very nice case to present.
Yeah. Atul?
I had one child who had something similar in the lower limb. And I think one of the things which one should remember is if you have features of spasticity and weakness together, that actually should think that you got something happening more in the brain. And if there is normal EMG, I think one has to think of vascular conditions. So any vascular pathology can, like hemangiomas and AV malformations can also present in a similar pattern. So I had a child which was referred from Surya Hospital. So they thought it's a child limping, but a brisk reflexes in the leg, but weakness as well. So when two things exist simultaneously, weakness and brisk reflexes, I think one must think of vascular conditions if the EMG is normal.
Great. So last question about this.
Maulin.
Yeah.
I wish to ask Dr. Anand one thing.
Yeah.
Because I don't know, as I read during my MBBS.
Uday, you can share the screen.
Yeah. So brisk reflex per se could be because of anxiety as well. So does it have a significance in the absence of upgoing plantar? So Dr. Anand, your...
Yeah, so brisk reflexes indicate some kind of cerebral irritability. Okay, it may or it may not be associated with upgoing plantars in all cases. So if you see the distribution of the infarct in this child, there is no involvement of the leg homunculus as what we know in the the way the leg, the arm, and other things are involved. So if the leg is not predominantly involved, you may not always get the upgoing plantars. So, but still, if there is an asymmetric deep tendon reflex, that would make me wonder, is there a upper motor neuron pathology going on, even in the absence of upgoing plantar?
Fine. See, so Gaurav, what's your question? I'm sorry, I missed that.
So my question is that, is there a possibility that plain MRI brain comes out normal and it can only be picked on MRA? Moya.
So MRI will detect the stroke, will detect this the infarct as such. But unless you ask for an MR angiography, they may not be able to see the the typical pattern of Moya. So they might say, okay, stroke, but what is the cause of the stroke? We don't know. And as a pediatric neurologist, even iron deficiency anemia can lead to strokes. So as soon as we get this, your child might want to go back again for an MR angiography. So one of the things we do is we predict that, okay, this may be a stroke. Let us request an MR angiography of the head and neck. And we ask the radiologist, can you do a dynamic imaging? Can you just update me on the phone? And if you need to do more sequences, we can get that done, just so that the child does not keep toing and froing from the radiology department.
So the nutshell, Gaurav, we are short in time, but nutshell, we must involve a neurologist and they will do the rest. And we think this differential in mind when we are dealing with unilateral weakness. Yeah, okay, let's go to two more interesting cases are coming up where more orthopedic involvement is there. So let's, Goda, please start with the third case.
Yes, sir.
Jayant, be attentive.
So we had a 17 days old baby boy. He actually presented to a pediatric orthopedic colleague of Sir in Mumbai, and then with complaints of short left lower limb and comparatively less movement of the left lower limb. He was born at term via normal delivery. There was no NICU stay. And the pediatric orthopedic surgeon over there got an ultrasound done to rule out septic arthritis or DDH. And Sir received a text from him saying that he's going to visit Ahmedabad for a month and that the child was 2 weeks old. Ultrasound was done and it was suggestive of dysplasia and he was given a Pavlik harness. So Sir texted Maulin Shah saying that he's as of now on Pavlik harness and he's going to visit Ahmedabad and to get a repeat ultrasound done if necessary. And these were his findings, like his ultrasound alpha angle was 52 and he came with a Pavlik harness on. So he was brought to us for evaluation after he came to Ahmedabad, and on examination, there was adequate abductor spread bilaterally also, and there was no obvious shortening. We got an X-ray done and there was no limb length discrepancy. So we repeated an ultrasound as we anticipated some improvement in alpha angle. And the repeat ultrasound did show an improvement in alpha angle. It was like 60 degrees then. And then we have advised them to visit the primary doctor in Mumbai and keep on the harness till then.
So, this alpha angle is 64. So I had doubt in my mind that why in a young child might have immature hip with 54 degrees is a normal, and we would consider harness only if the angle is less than 60 after 6 weeks or 2 months. But the colleague was concerned with he found apparent shortening and child was a bit irritable, so he wanted to rule out septic hip. So he advised an ultrasound, and when alpha angle is less than 60, we see the radiologist says it's a DDH, so you need to react. So he advised an harness. So I consider it completely appropriate. But the story, or what you say, is the turning point in this case starts now. I asked them that now you will be leaving for Mumbai in 10 days. So now you go back to the pediatric orthopedician and then he will take care of you further. Yeah, Goda, show what is happening now.
Yes, sir. So after 10 days, the baby was brought again, this time with complaints of excessive cry and reduced right lower limb movements.
So, Jayant, they were to go to Mumbai tomorrow, but they found that now right limb movement is less. So let us meet Dr. Maulin again and before going to Mumbai. And I was also surprised to see them in my clinic, and they were right that child's right lower limb movements were lesser than before. So what can be the cause of this?
It could be because of the Pavlik harness, could be femoral nerve palsy.
Right,
that is known to happen. So I would do a passive, examination and find out if there is any whether the restriction is active or whether the child is resisting passive movements also. And in a newborn, infection is always in the back of your mind.
Right. So the passively I could move the limb and the tone was less. So I thought that the child might have developed this harness disease, a the femoral nerve palsy before a week or so. And parents might not have removed the harness. And the grandma came to see the child, and then she recognized that this limb is not moving much. So I also thought in what you thought. And as child was crying, I advised a repeat. I asked them to take the harness off and do a repeat ultrasound just to make sure that there is no secondary infection, which earlier was very mild and now it has come up. Any other thought, Dr. Anil or Atul? Or anyone else?
So, the pain is shifting, no, sir? Pain is shifting?
I mean, it's not pain. The child is 2 months old, so it's not pain, but child is not irritable. Now, DDH children would not be this irritable, right? Mother will say the child has been crying excessively. Now we don't know whether the child is hungry or is what systemic thing is going on, or is it just pediatric thing. But mother was repeatedly telling me that is any.
So Maulin, was the hip movements painful? The passive movements of the hip rotation was painful.
I would say so, yes. And mom also said that whenever she changes the diaper, child would start crying. So first thing will come to our mind is septic hip, or an osteomyelitis or something.
Fracture, that is the other possibility.
Yeah. But X-ray, Jayant, we did the X-ray, which was normal.
Sure.
We did the X-ray to see the limb length discrepancy because the primarily short limb was the concern. So we measured the length and we found that there is no problem in the length. That time we did not find out anything.
Any fever was there?
No, there is no fever.
So if the hip is painful, I mean the harness was never removed by anybody.
They see for by this time 2 weeks they were well known. I mean they were well versed with how to put an harness on, and then I also explained. So they were changing.
So they were doing it. They were doing it
twice.
So at this point of time, Maulin, I would think of one or two possibilities. One,
Yes,
as you rightly said, that femoral nerve involvement.
Right.
But that should not lead to a passive pain on passive movements. So that's very
no pain.
You said pain on passive movements of the hip was there.
That is while changing the diaper, a child was crying, and any movement we try to do, abduction to see the abduction range, child would cry.
Yeah, that's what the passive range of movement at the hip is painful now.
Yeah.
So that is not the hallmark of dysplasia. So that is, again, you would not see such a situation in a femoral nerve palsy as well. I mean, this is unusual of that.
Yeah.
So I would think of two possibilities.
Yeah.
One is some sort of trauma to the hip while sort of tying the harness.
So some facial injury or something that sort, yeah.
And second is sepsis. Sepsis.
Generalized sepsis.
No, not sepsis in the hip. Sometimes, these are very, very subtle presentations where there's no fever, especially, I mean, usually I've not seen at the age of 2 months. But neonatal ICU stage, I see a lot of patients with the hip involvement.
Right. Yeah, but like the scans were absolutely normal. Our ultrasonologist is very experienced and he does all these hips but he said there is no collection or nothing in hip joint, both the side. Yeah. Anyways, Atul, you were telling something?
No, I was wondering whether because of excessive compression or they didn't remove the harness. Whether they got some condolences.
There was no this thing here, the marking, pressure marking, we see. Well,
spine X-ray, spine is normal. Spine X-ray is normal.
Spine X-ray is normal. Scurvy at this age, I don't think scurvy would present. X-ray was not showing sign of this pseudo paralysis or no. In young children at 2 weeks, we would see periosteal elevation that was normal. Okay, so let's see what surprise we found. Yeah, Joanne, you can move ahead.
Yes. So we suspected harness disease, but the mother said that the baby cries when she changes the diaper, especially when she holds the baby through the lower back. And sir also observed that there was dribbling of urine. So at this point, ultrasound of the spine was done. And it was suggestive of a possible intradural abscess.
So, what I found when I checked the child earlier, child was okay. But this time when I tried to check, there was constant dribbling of urine. So I asked mother whether is it the routine or, and then she said, for last few days, I also see that her urine output is more. I mean, she urinates more. But as the child would cry, there will be. So I found that there must be something with the urine control, or as Amar said, UTI is there or something. But as she complained that the pain is in lower back, so we advise in spinal ultrasound, which our radiologist is very keen. He recognizes the spinal dysraphism with scans very frequently. And See what he reported. He said there is a huge intradural abscess. Yeah.
And I need to leave. Thank
Yeah,
you.
thanks, Dr. Gupta. And but as there was no fever, if there is a huge intradural abscess, then there should be some fever or raised blood work, CRP. So we advise an MRI. Yeah, Goda, move ahead.
Yes. Since there was no fever, we advised an MRI. And these are the MRI images. We can see a intradural mass as well as a retroperitoneal mass. So this was causing the compression, the epidural compression, and it turned out to be a neuroblastoma.
Neuroblastoma.
So this is.
So I have had several neuroblastomas present to me with limb, hip pathology, but at an older, like 3 4 years
So this
of
is
age.
the youngest child, Jayant. I had
Yeah,
also a few 6 years old present with transient synovitis, turned out to be neuroblastoma.
Very
But
young
the
for
youngest 2-month old, and Dr. Naresh Bijlani, a pediatric neurosurgeon, was visiting Ahmedabad the same day. And let's quickly go through the follow-up of this case. The last case is very interesting.
So we referred to a pediatric neurosurgeon. Surgical intervention was done. These are the intraoperative images. The baby is doing well now. There is resumption of movement of the right lower limb and is on regular follow-up with the neurosurgeon.
So you can see there is some beginning of movement and chemo is going on. And child is apparently, I would hope the child would do well. Yeah, Goda.
So this was a paper which was a case report actually, which said that 5 to 10% of children with neuroblastoma present with symptoms of epidural compression, and more than half of these are diagnosed in the first year of life. So the learning lesson from this case is that babies with DDH are not irritable. Though Harner syndrome was thought as a differential, the excessive cry of the baby prompted us for further investigation. Painful spine and weakness of one limb pointed to an intraspinal pathology. Thank you.
Yeah. So, so this was the surprise to us. And Atul, any comment before we start the last and most interesting case of the day?
I think again this points to a couple of things that
Yes, we can share.
Irritable child in a straightforward case like DDH. One should think of other pathologies, and I think neurological findings may not be apparent in such a young child. But I think to get investigations done, always higher up investigations. If you have something at the hip which you can't explain, go to the spine.
Yeah.
You can't explain the spine, go to the brain. So I think those things are important.
That's right. Fine. So let's come to the last, and I would say the most interesting case. Jayant, please start.
Okay. This last case was an adolescent girl with unresolving knee pain. So this is her story. She's a 13-year-old girl. She was referred with right knee pain for the last 5 months, and she had no history of a definite injury prior to the onset of pain, and there was no fever, no history of joint stiffness, and no history of locking of the knee joint or knee swelling. And there was a negative family history of rheumatoid arthritis. She was being treated elsewhere, and she received multiple courses of NSAIDs along with knee bracing, and her symptoms were unresolved. And this is after 5 months of unresolved symptoms that she presented to us.
So Dr. Anil Agarwal, 13-year-old girl, knee pain for 5 months without any constitutional symptoms or trauma, no family history of rheumatoid. What would you, what further history you would like to derive? There is no hip pain, Amar. There is no pain.
Involvement of other joints?
There is no other joints involved. There is no skin lesions, Mudit. There's just she's complaining of pain around left knee.
The child doesn't have any history. So unilateral pains. I would like to also look for metabolic cause because there is no history of injury. Metabolic cause is because it sometimes happens that the symptoms start in one knee and then subsequently other joints are involved. So metabolic cause, systemic cause basically.
Yeah.
Systemic,
So
yeah.
she is, during this time, she has been playful. She is going to school. And it's not like that the pain comes when she is bearing weight. So in metabolic or stress fracture, we see that this patients would have pain while they are doing activities. But this girl is going to school, participating in the school sports PE classes, but she would complain for pain every day. And they have been seeing senior pediatric orthopedicians also in town. And yeah, Jayant, you can move ahead. What is further?
Okay, so coming to the examination, we noticed a right thigh wasting. On the knee, she didn't have any effusion or localized tenderness. Her right knee range of motion was full and painless. There was no instability at the knee. On the right hip, there was terminal restriction in the external rotation and abduction.
So
The
now,
spine-
like, someone told hip movements. So as we routinely do in a prone position, I try to check her rotation. And usually if there is some hip pathology, we'll find limited internal rotation. But I found that probably there is restriction of external rotation. But I was not sure. Sometimes, I mean, it is not a short restriction, but I had a bit doubt that this is probably restricted. My fellows say that there's normal hip range of motion when they checked the child earlier. Yeah. Yeah, Jayant, let's go further. So blood work.
So her blood workup came negative for infection and inflammatory pathologies. She also underwent multiple MRIs, and her last MRI knee images also it were reported normal. There was no intra-articular pathology, no ligamentous injury.
The gait was normal, Mudit. The gait was normal. Sujit, the X-ray TBH was done twice, and that was reported normal.
You have to go a step higher to the spine then.
Okay.
What causes thigh wasting? A lot of thigh wasting you mentioned.
Yeah, thigh wasting on one side.
So whether she had any petrolofemoral problems, any mechanical problem with the petrolofemoral joint?
She never, she did not this thing suggest that there is any locking or any patella dislocation. And MRI did not show any marrow edema or this vastus lateralis or medialis edema is not there. There is no synovitis, Dr. Kishore. So if there is no synovitis, how the biopsy would turn out to be normal? Here you can see there is no synovial thickening. Spine, of course, we will talk further about it. Spine, there was no tenderness clinically. Muscle power is normal, Mudit. Reflexes are also identical on both the sides.
How do you explain the wasting if she is doing normal activities?
I don't know. That's why you are an expert.
So that's why I think we need
What
to
is
rule
missing
out a
here?
neurological cause. I think we need to rule out, get except the MRI of the spine done.
So I'll tell you the story. I was like confused that why this is happening. If it is not coming, hip X-ray is normal, knee is normal, the spine mein kuch nahi hai, reflexes are normal, then where is this coming from? And then the father brought out an MRI film of hip. He said that the radiologist is my friend, and he said, let me screen everything. And then he did MRI of hip, and he found something. He said something abnormal is there in the acetabulum. This might be infection. So you now change the pediatric orthopedic surgeon, go to other and show what is going on. Now they seen to one pediatric orthopedic colleague, and he said that this is okay. I mean, this knee pain is not, it cannot be because of this. So he said, just forget about it. But these are the MRI images, Atul.
Yeah, so there seems to be lesion somewhere in the
Acetabulum.
acetabulum area, especially near the anterior wall of the acetabulum, and there's diffuse edema around that.
Yeah.
And I don't know whether there's a nidus in there in that area.
Yeah. So, I mean, it looked like to me also like it is probably an osteoid osteoma or something that sort. So then I talked to the child herself and inquired that, do you have more pain at the night? And then she said, and Raji also asked the night pain. Then she said, my pain is more in the night and early morning. Daytime when I go to school, I am okay. But parents thought that they gave analgesic every evening, and that's the reason why she is fresh in the morning. But the matter of fact, she was receiving analgesic constantly for 2 months, and she had more of a night pain. So, Jayant, how would you proceed further? This is a very rare sight to have osteoid osteoma. I had never seen in my practice.
Why not other differentials, sir? Why not other differentials? Why just osteoid osteoma?
Other differential is infection, no?
Yes.
Yeah. So
probably do a CT.
Exactly.
High resolution.
Yeah.
Just to see if we can pick up a nidus, and talk to the radiologist beforehand and ask them to do really fine sections.
Fine cuts. Yeah, that's what we did to see, because if, as Dr. Anil said, an infection can be also a possibility. So we did this fine cut CT, and that brought a nice view of a nidus, as you can see. So at one point, we were very happy that we could diagnose the condition, which was hidden for 5 months. But the second problem came, that how to approach this. Because
very simple. Just dislocate the head.
Usually, we do this percutaneous CT guided radio frequency ablation, but here the vessels are just lying in front of. Can you show Joanne's?
Yes.
Where are the vessels in CT?
So the red marker is the femoral vessels, just at the trajectory of the. If we do a percutaneous this thing, so it would directly come in the trajectory. This red mark.
So while I was happy that we could do the diagnosis, and then I talked to, can you go back to the one slide? Then I talked to intervention radiologists, and they also said, sir, push karke, open karke karo. It will be difficult by percutaneous means. So, Jayant, how would you manage this case?
I would do a surgical dislocation and approach it. I mean, you can come, transiliac through an anterior approach. But
the problem is, Jayant, even if you open, once you open, you don't know where the lesion is. It's difficult to locate on X-ray.
So it's difficult. You just have to go by anatomy, really. And there is a possibility that you could somehow find a trajectory to put a guide wire in it, get a CT scan, and then leave the guide wire in place, shift the patient to the OT, and then follow the guide wire. I mean, it's a very roundabout. And
I think with the modern navigation and the modern O-arm, which is present, I don't think you need to open it, to be honest. These, if you go to some of these very competent.
So one suggestion by Atul is O-arm, but O-arm is like Atul. I'll tell you, the problem with this was, we can decide our trajectory, but if we do a mistake, then we might penetrate the joint on one side or the peritoneum on the other side. See, we do routinely CT guided drilling, but sometimes, we may overpass. Here we have very narrow place. Even by using an O-arm, it can become a bit challenging, So I agree that using an O-arm, but Amardeep said, Amar is in Canada, so he can say so, can use navigation if you have. So Amar, that thought came to our mind as well. And it's already 9, so I've asked Joanne, please take us through the case, how we manage this.
Okay. So we planned a O-arm and stealth navigation assisted mini open excision of the osteoid osteoma. And this was a setup, and that's how we draped her. So we draped the contralateral side also. And this is her view through the O-arm, and the optical tracking frame is attached to the contralateral ASIS. And this is we did a mini open anterior approach, and we retracted the vessels medially, and we approached the acetabulum. And in real time, we marked out the trajectory for our probe. And we can see the trajectory is going to the lesion directly once all the vessels have been retracted and safeguarded.
So
And
the importance of navigation is not only guide the trajectory, but also the depth of penetration. Trajectory may be right, but if you over penetrate, then you might penetrate the joint, or you might penetrate the inner side of cortex and you enter into peritoneum. So that's how navigation is helpful. And I took help of my spine surgeon and my orthopedic onco surgeon. And they helped me with this because we have never used navigation in pediatric practice, you know. Yeah, Jayant.
And so this is the end. We drilled it and then we curated the lesion. And her post-operative, we kept her non-weight bearing for the initial 2 weeks. And we noticed that her analgesic requirement reduced since the day 3. Her pain visual analog score reduced from a 7 pre-op to 0 within 2 weeks. And she gradually progressed to full weight bearing within 3 weeks. Her histopathology report, since we took it out piecemeal, it has multiple fragments and it came out as osteoid-osteoma.
The cervical spine osteoid-osteomas also are tackled by navigation, and I think it's a great tool to use. So interesting case, Maulin. Very nice presentation.
And this is the interesting slide.
This last follow-up, and
so she has started participating in Garba, and the family is so happy. They sent me this video yesterday, thanking that now she is back to normal. She is a very active child, very interested in dancing, and so with this all 4 eye-opening cases, I wish you happy Navratri, you know. And I'll have final comment from all the 3 experts. And I thank you, Godha and Jayant, for presenting it so nicely. Yeah, Dr.
Interesting
Anil.
cases, very interesting cases, Maulin, and certainly lots to learn, from these unusual presentations. And one must always be vigilant, I think, for subtle signs, subtle symptoms, and always think of pathologies. If you can't explain a child having pain or irritability beyond 2 to 3 weeks. So really good cases. Thank you.
Yeah, Jayant.
Yeah, Dashara special. All cases were interesting, and it goes to show the importance of us as part of a multidisciplinary team. That we are a lot of times we should never think that we need to make the diagnosis. There are plenty of very intelligent people around us whose help we can take. And in each of the cases, I think you have taken somebody else's help also, which has helped you basically address the child's problem. So I think that is an important message, particularly for the juniors, is take the help of others and also ask around for advice. Never be too proud that we know all the answers. Sometimes what is a very rare pathology for us will be a very common pathology in another specialty. So always talk and interact and discuss cases whenever you don't have clear answers. Thank you, Maulin. Very nice case.
Yeah, Dr. Anil.
Yeah, nice cases, sir. Basically, nice cases, sir. Basically, I would like to highlight the take-home message. First is that you need to be broaden your perspective when you see. You don't narrow down the things to that this is this diagnosis only. You need to have a broader perspective when you approach a patient. Second thing, when you cannot find a cause at a particular joint or a particular section, then examine the upper and the lower portions of the patients. So you might have a clue over there. And third thing, which sir has rightly pointed out, that you need to seek second opinions. Be open to the second opinions of the experts. if you are not able to find cause. Even your colleague, even your second surgeon or a pediatric orthopedic surgeon may be able to find out the cause. You are stuck with something. Take the help of others.
That's right. And always listen to family. You know, sometimes mothers will give you some important history. So I always call mother if she has not come with, and sometimes they give you important point. Being senior is not easy. More challenging cases will be referred to you, and the key thing is to take help and do this stress management, and always have another approach, another view. So thank you very much for your presence, and we'll come up with more interesting cases in future. Thank you for your precious time, Jayant, Anil ji, and Dr. Atul. Thank you very much, and all the participants. Thanks, Amar, for your inputs.
Thank you, sir.
Thank you. I'll end the meeting now. Yeah.